Great. So thank you everyone for joining me here today. Today's BRiTE Center presentation is going to be by Dr. Colleen Stiles-Shields. Dr. Colleen Stiles-Shields is a pediatric psychologist and an assistant professor at the Institute of Juvenile Research, the AI.Health4All Center, and the Department of Psychiatry at the University of Illinois at Chicago. Her research focuses on utilizing digital mental health and telehealth as delivery mechanisms to reach and improve behavioral health targets for pediatric populations. Today, her talk will focus on the importance and impact of lived experience in improving the reach, uptake, and efficacy of digital mental health tools and interventions among youth. So with that, Colleen, please take it away.
Thank you for the intro, Aria, and thank you all for having me. Again, I apologize for my voice. I don't usually sound like I'm going through puberty, but we will get through this together. I've got an arsenal of drinks and cough drops in front of me. We're gonna have a blast. Okay, so let me get my slides rolling. Let's see. Okay, and let's get this ball game rolling. So hi, I'm Colleen. It's great to meet you all. I know several of you by name or in real life, and it's fun to be with this group. So thanks for having me. So today we're gonna go on a journey. For those who are unfamiliar, I talk very quickly, but we'll get through this together. So I'm going to do a little bit of an intro. You'll learn about me. We'll have some common language we'll start with, go through some background. The spoiler alert is there's a lot of problems. Keep your phones out because we'll do a poll in the middle. And then we'll go through some of the lessons we've learned in our lab so far, talk about some folks to follow that are doing other really cool stuff, and then end with some questions that need answers, because I think this is probably a really smart group, and I'd love to hear some of your thoughts. All right, so who am I and where did I come from? I know it's a mixed group. Whenever there are trainees, I really like to explain where I've come from, because it usually looks like speakers had a linear path, and most don't. And I'm one of those don'ts. So again, my name is Colleen. I lead the Matters Lab at UIC. I'm a pediatric and clinical psychologist, but I also am a former social worker. So we talk about interdisciplinary engagement. I can get into arguments in my own head. Also, not to brag, I've met Cookie Monster in real life. So that's a personal thing I need to share with everyone from here on out. And I'm going to be talking a lot about Chicago, and I really love Chicago, and you can tell by the fact that I have a very full Chicago bingo card. So I've done all of my training and research and work in Chicago, and can tell you that each institution has its own fun flavors. I also have been on teams my whole life, and I think that's how I approach my research and my problems and my questions, and I think that's probably how a lot of you all work too. And I ran cross country and track from 4th grade through senior year of college, so teams make a lot of sense. And I think especially when we're thinking about tech and engaging folks, I was a long distance runner, so I'd be that weirdo who's just circling the track at a track meet, and while that was happening, there were people throwing discus and doing long jump and throwing shot puts. And so people had very different goals and things that we were doing, but it all came together as part of a team. And that's really been how I've approached this field. It makes a lot of sense to me. So I'm gonna start with alphabet soup. We all like to do a lot of acronyms. I think most of the people in this room probably already use the same acronyms, but we'll still start with that. I talk a lot about digital mental health, or DMH, which is technology or related tools like apps or websites to track and improve mental and behavioral health targets. Other fun acronyms I like to throw in this umbrella, as do many others, are DMHI, like digital mental health intervention, or digital health intervention. And sometimes we also throw around TES for technology-enabled service. Those are really fun. And I'm going to be talking a lot about engagement today, which again, I think none of you are strangers to, but it can mean a whole heck of a lot of things. Primarily, we're going to be talking about objective use of engagement in terms of frequency or duration, but a lot more so about subjective experience, like how positively folks view a technology. Okay, so why am I here? So I was a social worker in a previous life and got real annoyed real fast that there's treatments that work pretty well for folks, and it's just so hard for kids and families and young adults to get to care. And so many of those obstacles are put in their way through no fault of their own. So I like to joke I was a glutton for punishment and went back to grad school and switched gears to clinical psych, because I thought that digital mental health and telehealth would be a really great way to maybe overcome some of these access barriers. After all, for a long time, that's the start of every digital mental health paper, arguing that this is the way we reach everybody. So I headed over to work with Dr. David Moore at the Center for Behavioral Intervention Technologies at Northwestern. Had a lot of fun, got to work on some apps that, even dogs had access to. So it really seemed like things were going well. And really had a lot of great experiences seeing things built from the ground up, including strange drawings I did in my own office, talking to myself, turning into functioning apps that turned into things people actually used, and arguably it helped those people. So yay, that's fun. Around the time I was finishing up, more and more was coming out in the Ped Psych literature that digital mental health and digital health might be a way that's effective to help pediatric populations. So this JAMA Peds piece is rapidly aging, but did come out in 2017. Cut to a few years later, I was fortunate enough to be invited to work on this fun team with Dr. Laddie and Dr. Graham, where we reviewed so many things that are out. There's a lot of really great stuff that's out there, and a lot of great things that are really trying to make things more accessible for folks. But because there's so much out there, I'm more of a stance right now of maybe let's not reinvent the wheel so much. What are some adaptations that we can make for pediatric populations? So I know this group is specifically interested in learning a little bit more about Ped Psych. And I know that when you hear the word pediatric, you get a certain vibe. And I'm a Muppet type person. So I lean into these representations from Dr. Glaucomflecken. If you don't know who that is, please look him up. He's got really great videos out calling out a lot of health insurance problems too. But when I entered pediatric psychology, I was really blown away by how niche it seems. And yet it's one of the most broad fields I've come across. Because when you think about helping kids, one, there's a condition. So are we talking about a specific acute or chronic condition? Or are we talking about health space? Like I work a lot in primary care, which means it's every kid with every kind of problem coming in. Additionally, when you're talking about kids, that's a really expansive term. That could be someone who's not born yet, and that could be someone who is 25 or 30. So the people who work in pediatric oncology, someone who's 30 could be in a peds unit with a child cancer. Additionally, caretakers are a really important part of Ped Psych because they're the ones really doing the magic in the environments. And caretakers can be a teenager, and caretakers can be grandparents. So when you think about Ped Psych, it's actually an incredibly diverse lifespan approach to doing work. And something that's been tricky in digital mental health and digital health broadly is that a lot of things have not been developed considering a minimum triarchic stakeholder involved in the data, right? So you've got a pediatric patient, you've got at least one caregiver and at least one provider. And for a lot of conditions, all those three people are going to be really interested in the data, but not all three of those people might be able to share that data or view that data equally. So there's a lot of players in Ped Psych that you've got to consider. Now, we can't overlook that things are not going well in our world, in our country. There is a immense youth mental health crisis going on. So also when we're talking about Ped Psych, we might be talking about a condition or conditions or kids being in a healthcare environment on top of there being a youth mental health crisis. So that's a lot of factors to be juggling right there. And, the thing that brought me back to grad school, this everyone's got a phone in their pocket. This might be a way to get to the kids. Those arguments keep being thrown out there, but we're not doing a good job getting to the kids. As my colleague, Dr. Alex DeHojos posed last year to JAMA Peds, adolescents are still waiting on a digital health revolution. We've really just failed to get stuff to kids at work. And that's not on us, not on them. So let me back up again. I'm going to talk about Chicago as I previewed to you. I have done all of my work in Chicago. I'm a lifelong Chicagoan. I'm a big fan of Chicago. And so I like to think a lot about how we might improve digital mental health's reach and uptake in terms of my fair city, because I love it. And the thing is, when you love something, you're aware of the things that aren't going so well, because you want something that you love to be better and always be its best version. And Chicago has a lot of problematic histories and current practices. It is a built city. And it was specifically about with redlining in practice, which has resulted in very specific communities disproportionately being impacted by health disparities. So Chicago is often a place that's pulled out in the maps that show how drastically different people's lifespans are based on where they're living. And Chicago's had a bad rap for a very long time, I would argue since the days of Al Capone, of being a violent city. And so some people come back with, well, these differences must be because of community violence, right? Like Chicago's got problems. Those are things that are said to me frequently. But when you take the data apart, it's very clear that actually these health disparities are a direct result of systemic racism that have happened in Chicago. And I'm focusing on my city because I love my city, but Chicago is not alone in this. So this is something that we need to reckon and think about whenever we're doing our work, because our work is meant to overcome a lot of these disparities. And these problems really do keep me up at night, because in the communities that I tend to work in Chicago, the kids and families who are seeking care have everything in their way. So in some cases, if we're not able to engage them with tech, they're really not getting touched at all by some evidence-based care in some cases. And so that's really a shame. And that's really something that we could do better. So talking about Chicago, the communities that I tend to focus on are the west and south sides of Chicago, which were built this way to have systemic disparities put upon them. And COVID certainly didn't help. So there were already vulnerabilities that have been made worse in the last few years. For here, you can see the west and south sides, the dark parts of both of these map for both physical and mental health. And we're part of the problem, because we argue that digital mental health is a way that we're going to overcome some of these barriers, but we're exacerbating some existing things, and in some cases creating new problems. So for example, if you haven't checked it out yet, I really like the University of Chicago's Data Science Institute's Internet Equity Initiative. So it shows Chicago, but many other cities as well, the disparities that happen in terms of home broadband internet access. And so when we're thinking about things that we're designing for kids and families, we need to figure if they have this access at home. We also need to figure what their context has been these last few years. Were they just kind of left hanging when everything went socially distanced for school? Yeah, probably. So there's a lot of things they're trying to overcome. If you're interested in learning more about broadband internet access and some other ways that maybe digital health isn't making things as accessible as possible, I highly recommend this awesome paper by Dr. McCall et al. On a way to address digital redlining that's happening here in the US. Okay, so all this is to say, I will probably say this for the rest of my life, because it is worth saying that systemic changes are desperately needed in all kinds of care, not just our own work. So that's something to always keep in mind and always bring up in every room that you're in, because it won't change unless we keep talking about it. Okay, so where to start? So imagine that your kid's running a little bit anxious. Imagine that you found that out when you were in a doctor's office. You might start by going to the App Store. And if you type in child plus anxiety, oh my, so many things come back to you. I would argue I do this for a living, and I get a little overwhelmed about everything that comes back to me. So I don't know how we really expect a lot of people to navigate the vast amount of what can come at them. And I will say, you know, we try to do our darndest when the pandemic hit. Dr. Alex Deho, Joe Martha, Neri, and I put this piece out for the Ped Psych folks to see, like, this is kind of how you can start weaving through things to find apps. I will say there's lots of people doing really helpful papers and work to try and get stuff out to folks, including Dr. John Toros and Dr. Stephen Schuler. And that's wonderful. But even as someone who wrote one of these papers, I would say this is not moving the needle. So it's nice that we do this, but like, it's not helping people actually find things a little bit more easily. So I could go on and on about things that I think aren't going well, but I'd rather actually have you learn from some of the experts. So in the Society of Pediatric Psychology, which is the Division 54 of APA, we have a special interest group focused on digital health. So arguably we got all the digital health folks that are involved in Ped Psych together, and we asked them about what the problems were. Specifically in the tradition set out by Betis et al. In 2022, we did a pre-mortem with the idea being, let's pretend this just died. Digital health for peds just died. What were the causes of death? And in finding the causes of death, we try and figure out what we can do to prevent that death. So that's the idea of a premortem. We got everyone together, said, here lies digital health. It failed spectacularly. The NIH will no longer fund it. It's done. What went wrong? We had 2 jam boards. The first jam board was we had everyone contribute causes of death. And once we did that, we were able to sort them as a group and sort of figure out themes that were cooking from what people were contributing. And then we opened a second jam board asking, what are clear actions for addressing each of these failures? Essentially, how can we save the life of digital health? This paper is still under review, so I'm not going to tell you our solutions quite yet, leave you hanging. But the 5 core themes related digital health threats that this group identified was, we became stuck in proving efficacy and did not make an impact. We assumed we knew more than youth and their families. We replicated, exacerbated, or created new disparities compared to in-person care. We underestimated the importance of a human touch. And we did not know how to advocate for digital health as a clinical transformation. So that's what the experts think the problems are right now. All right, so to give my voice a break and give everyone else a break as well from hearing my squeaks, I'm now going to ask you to get your phone out, scan this QR code, or you can go to menti.com and use the code 53799877. And we're just going to do a little experiment on our own. So first, think about what's a tough thing that you've experienced in your life in terms of your health or mental health. And this will be anonymized. I can't see what happens on your side. So this could be any kind of experience that you would identify as a tough experience, because everyone's had at least one. Okay, so we've got anxiety, stress, loss, depression, breakup, suicide of friend as our top hitters, but there's a variety of things like isolation, sleep, racism, loneliness, childcare lapse, family being sick, not being heard, no solutions, financial concern, chronic illness, financial strain. Thank you all for sharing. And I think this is always just a lovely human experience to see that everyone's gone through something. And especially when there's clinicians in the group, it's always, I think, helpful to see what emerges in terms of a symptom or a diagnosis and what is something that's systemically put on someone and what is something as a barrier to care, because I've never done this without a barrier to care appearing in this one. All right, ready for the next one? All right. Oh, come on, PowerPoint, come with me. You can do it. There we go. All right. When you think about the hard thing that you put down or hard things that you put down, did you use a digital health tool to help you then? Okay. I'm going to give you the spoiler alert that every time I do this, nope is the top answer. Okay. If you did or would be open to using a digital tool for this tough thing, what did you use? Okay. So we've got internet searching rabbit hole, which I always feel is underreported because, I think about also my like postpartum experience, like anything straight, like how much Googling I did of like, is what's happening to my body or my child's body normal? Like, I think we do it a lot more than maybe we expect. But it looks like apps are a heavy hitter as well as blogs, little bit of YouTube, TikTok, and some of wearable trackers. All right. Last one. What did or would get in the way for you of using a digital tool for your tough thing or tough things? Okay, so we've got heavy hitters of time, habit, cost, impersonal, knowledge of fit, efficacy, privacy, inconvenience, accuracy, forgetting, generic, no support, bad options. Okay. Now, everyone is on a technology device right now because you're listening to me through your computer, and everyone just answered this on a technology device, and arguably we all work in tech in some way, and these are barriers for us. It's kind of bananas, right? So if arguably, like, we're probably privileged in the tech space because we know a lot of people that are doing smart things, we're pretty confident and feel comfortable in tech, and these are our problems in accessing things, like, it's got to be pretty tough for the average person out there, huh? Okay. I also am kind of blown away by every time I do that a lot of the top concerns that people haven't changed that much from when I asked people with depression about this in like 2016, 2015. So even though tech is developing rapidly and doing a lot of cool things, our field isn't really keeping up and making sure that people know what to find when they need it. So we can do better, right? When you know better, you do better. Let's do better. All right. So, not saying I have all the answers. We're actually about to talk about things I've screwed up too. So I'm going to switch gears a little bit to what we've been doing at our Work in the Matters lab. So our lab is grounded again in Chicago things. We're grounded with the philosophy of our former First Lady's mom, Mrs. Marianne Shields Robinson. Again, my name's Colleen Stiles-Shields. I like to walk into places and introduce myself like I'm Cher. I'm like, hi, I'm Colleen. And then this joke doesn't make sense. Anyway, she has been quoted by Mrs. Obama several times as saying that she does not think that Michelle Obama and her brother Craig are special. And I do need to always go on the record and say that I think Michelle Obama is very special, and I'd be very embarrassing should I ever get the opportunity to be in the same room as her. That said, I completely agree with her mom. So she tries to remind people that neighborhoods like the South Side of Chicago are packed full of little Michelles and little Craigs. They're in every school on every block. It's just that too many of them get overlooked and underestimated. And this is something that our lab uses as a philosophy to approach how we want to adapt technology for pediatric populations. And this has driven a lot of our recent work where we're calling people to action too. So in 2022, we put out there that technology or things that are grounded in user-centered design and human-centered design sounds so great, right? But there's been a lot of talking the talk and not walking the walk. Because if we really want to think about engaging end users, we haven't necessarily been inviting the folks that we're really trying to reach to the table. And we're not necessarily inviting them more than once, which is also a problem. I was checking to see if he was on here because I know he's in your group. A shout out to Dr. Erin Lyon. Thank you for quoting directly from our paper and also giving me a really easy pull quote to call out what I very pregnantly wrote at the time. So what we argued, and Dr. Lyon was kind enough to repeat, that despite HCD's framing as a collaborative approach with end users, we have to recognize that it's been grounded in a lot of power structures that we need to rework and rethink and be really purposeful about. The idea that there's a potential of a power structure in HCD that a designer, say a cisgender heterosexual white male attempting to uncover the needs of a marginalized community or user to create a product, when actually users and communities may already have really strong notions of what might work for them and don't need these ideas to be uncovered for them, and are less likely also to share those ideas if they think someone's trying to uncover it for them, right? It's their thought. So we followed up this year with a paper arguing that if we're going to increase digital mental health reach and uptake, we need to partner with youth. We have to throw out this one-time participant model and really figure out how to adjust a lot of those power structures. And we're really fortunate that we have decades of community-based participatory research methods to learn from how to do this. But also, we need to struggle with this and figure some stuff out. Like, I don't know how to power share with a teen over Zoom. I don't have that answer. If you do, please tell me about it. Please write a paper about it and tell everyone. That'd be great. But we need to shift more to a partnership and invite youth to be co-authors and help us respond to reviewer comments and figure out how this works for every little piece that we're doing. All right, so some things that we're doing in the lab and some lessons that we've learned along the way while we're stumbling. One lesson is grounded in the COVID-19 pandemic. And I put this slide here with our faces there, again, with the call to trainees that if you see a gap in something, please speak up. I was at home with my 1.5-year-old when everything locked down and very early career and still am. And reached out to the editor of our flagship journal being like, is someone going to write a paper about how everyone could shift their research to virtual? And she was like, yes, please write that and have it to me in a month, which was a very generous, lovely thing that she did and not something that I was seeking, nor do I think that I was the person to answer all those questions. But I do put this out there that, again, like if you see a gap, ask about it because you might be someone who can get the ball rolling. Anyway, when COVID hit, we had to move to social distancing. Remote clinical and research activities were the norm. And there were also a lot of funding mechanisms that came out to fund things that could be rapidly deployed to people that were really suffering. And one of those funding mechanisms went to developing the energy system, which stands for Emotional Needs Evaluation and Resource Guide for You. And the energy system was designed to be deployed in Chicago, specifically targeting the West and South Side communities. It's for people ages 15 and older. And they were asked a series of mental health questions that we identified through some item response theory, as well as resource questions, such as, do you need help with childcare, healthcare, finances, like variety of things. And based on their answers, they would get personalized links to tips and resources that were freely available, could be accessed at any time, and all of this was anonymous. And this was really well received when it was put out into the community. Community members were coming up at events being like, oh, thank you, my uncle needs this, my kid needs this, my brother needs this is what we've been looking for. Community partners were over the moon. They wanted to share it with everyone and give out flyers. And despite that reception, it was only open 212 times during its first deployment, which is nothing. So despite the excitement that was being given, despite the partnerships with communities, it didn't get to the folks who needed it. And I always joke, like, and that was done by someone who maybe might know better because she's been lecturing you for a half hour about it. But the lesson being learned that if you want to get something out to folks quickly, it's great if you're trying to go help, but like quick isn't necessarily always going to get you what you need. You've got to start with the partnership from the beginning because the engagement's not going to be there. Again, even when you've got the best of intentions. If you're curious, for those who did use it during the beginning of the pandemic, it was mainly adolescents and young adults, mainly females, maybe people identified as straight or non-Hispanic or Latina, maybe people who identify as Black or African American or white. And then again, we deployed this in Chicago for Chicagoans, and the marketing was very clear there. And only 3/4 of the users who gave demographic information were from Chicago. And y'all are out west, so like the Midwest might just blend together in your mind, and I get that. Geographically, Indiana and Wisconsin make so much sense for something deployed in Chicago. California, New York, and Texas do not. So that was quite a surprise. So our lessons from that were, one, you need to always remember digital is never entirely local, no matter how much you aim for it to be. And like I said, even with the best of intentions, in the greatest of emergencies, there's always time to partner. If you want, partner with the people that you want to get it to, because otherwise that hurrying is worth nothing because it doesn't get to people. I'm happy to report the energy is in her glow up phase. We are rebranding her to be the Mars system. We're working with community members and community engaged clinicians, as well as an industry partner software for research to make her look a lot prettier. And our goal is just to have Mars be available sustainably in the community. We'll continue to update it as a resource that can always be accessed by anyone who needs it. Okay, so the other thing that has been keeping us busy and giving us a lot of lessons is the TEACH system, the Teen Assess, Check, and Heal system, which, again, going back to the idea of adaptation, it's taking tools and things that have already been developed and exist, but figuring out how it should be packaged in partnership with kids from the west and south sides of Chicago. So first, there is a mental health screening component. We are using the Kitty Computerized Adaptive Test, or KCAT, which was developed by Robert Gibbons and his team over at UChicago. It takes item response theory on a very large number of mental health items to really hone in on what a person is endorsing. And it gives severity scores for 8 diagnoses in under 5 minutes. It can be administered to a child, it can be administered to a primary caregiver, or it can be administered to both. There's also an adult version called the CAT-MH, which also is really cool and works even faster. So the TEACH system uses the KCAT, and then based on what someone's score is, gives them feedback, which is informed by the kids. Like, do they want to hear the word anxiety or no? That's only something they can answer. I'm a psychology nerd, so like I love the word anxiety, but that's not for everyone. And then we are taking tools and resources that are publicly available and freely accessible, but we're having the kids package it. So kids are they have a really great sense of what's genuine. And so if you take a kid from the west and south sides of Chicago who often live in communities that are systemically disadvantaged for a lot of reasons, that a lot of kids that are primarily identifying as Black or Latina, that have a variety of different identities and experiences that overlap, they're pretty right if they say that some of this stuff wasn't developed for them. It wasn't developed for their age, and it wasn't necessarily developed for the variety of identities and experiences that they've had. So just putting stuff out in front of them is not going to work. Like I said, this is all freely accessible, but they're not being accessed. So we're working with the kids to better understand, like, would you ever click on this? Why? What would make you click on this? What wording would you need to see? What would you need to learn or know about this to think this is worth your time to click on? And I will give you, again, the spoiler alert. They really like the apps and really look how it looks, and they're never going to download it. And they just tell us that. But they still want the offer. So like, you still also have to put some things in front of them, whether they'll take it or not. And with the TEACH system, we're actually trying to just better understand engagement. When we first worked on this grant submission associated with it, we wanted to track clinical outcomes because I want to make people feel good. And the NIMH responded, rightfully so, that we know if you put evidence-based things in front of people, people tend to feel better. But we don't know how to engage kids, particularly kids that we tend to work with in Chicago. So we're very simply trying to understand, does any interaction with the system change their understanding of symptoms? Does it change their confidence to act on their symptoms? What their likelihood of using any DMH tool is, and then their actual use. And some of these question prompts were chosen because those are individual level barriers to care that have been identified. I've yelled at you a lot about systemic barriers, and those need to keep being worked on. But right now, we want to put a little bit of empowerment on the kids and better understand how those individual factors are working. So when we started this work, we started by talking to some kids and caregivers about just what their experience is in life generally, and then what their experience is with tech. And I will start off by saying that we were doing this as a lot was coming out of social distance, and the kids still really preferred remote research. Texting was so much easier for them. Texting was so much easier for their caregivers. It was a lot easier for teens to grab their parents in the moment for consent, doing that all virtually. Also in Chicago, in some neighborhoods, if there is gang involvement, it's not always safe for a kid to hop on a bus and go from one place to another. So keeping them where they do feel safe is an ideal thing to do. And Zoom works out fine. It really does. Even with Zoom fatigue, the kids came, and we just had always that if there's any stuff that we're doing with more than one participant at a time, that there's always two people on that call, so someone can just always be in charge of chats, because some people are also just more comfortable putting in chats instead of using their words. Now, every kid that we talked to expressed concerns about their mental health and the mental health of their friends. The top hitters that they talked about were depression, stress, anxiety, and bullying and cyberbullying. And something that I like to think about in this work is, when we offer something and we get so excited because we're like, this is a really great tool, like everyone's going to love this. And we're excited about that one discrete thing, and we don't understand why they're not using that one discrete thing. And the teens and parents were really telling us that you got to understand the smartphone is like a fire hose. And so we're recommending something in the current of a fire hose, because they're getting every bit of news, including a shooting down the street or more COVID outbreaks, every weird experience or uncomfortable experience they've had on their phone through social media, or getting a text with a fight with someone. Like, every good and bad feeling is in that fire hose. And so we're recommending a tool in a fire hose. And so that helps us better understand a little bit of what we're competing with. Additionally, the caregivers were super excited about anything that would help from a behavioral health standpoint. So a tool that's grounded in better sleep, that's grounded in helping you understand what you're eating, what your screen time is, your steps, super on board. The second you bring in the idea of like, this will help with stress and giving you some coping skills to learn how to deal with these things, the breaks were full on, because parents had this stance of, I don't want my kid to be dependent on their phone or an app to manage their mood. That really freaked them out. And that's really helpful to know about, especially when we're thinking about sort of a marketing campaign of like how to hook folks into trying something, that saying like, this is a skill your kid can learn beyond the phone still isn't something that makes them comfortable in terms of a mood perspective. Also, everyone's just savvy. Like, our phones pick up a creepy amount about us, and people are learning that more and more. So they really want to understand what's happening with the data, with the privacy, what the goals are with the data and privacy, and how that's going to be shared. So today we're really working with the kids, also building a library of like, what would you send to a friend if they were feeling stressed or sad or down? We asked the parents and caregivers the same thing. I will say I go between parents and caregivers. The last study I just talked about ended up being everyone was a bio parent who participated, but it's very common also for people's primary caregiver to be someone who's not a bio parent, whether that's adoption or an aunt or uncle or grandparent too. So that's why I've been dancing between those two terms. But we've been asking people a lot about what they send to people, because we'd really like to hone in on what's actually being used, but can be grounded in an evidence-based stance. So for example, people have a lot of thoughts and feelings about social media, and there's a lot on social media, and a lot of people are focusing on the bad. But when there's a lot of things, that also means there's a spectrum that includes good. So there's some really cool TikToks that like can explain progressive muscle relaxation in like 30 seconds and does a decent job. That's great. So we're collecting more and more of those things and getting them more and more in front of the kids to see what they like and what they use and what they want to share with friends. And what, you know what, if they use it outside the system, that's also great by me, because that means the kid using something that's going to help them. Other things we learned is that, the kids were talking about a window that's open, and we don't know for how long this window is open. So when everything went remote, and especially schooling went remote, kids for the first time were saying, my gym teacher was asking about my emotional health, and that was totally fine and welcome. And my gym teacher recommended me an app, and I loved it. And I've never heard a kid talk about their gym teacher asking about feelings and giving resources and them checking it out before. The kids were voicing so much more that trusted adults, they wanted them to have a genuine ask about how they were doing. And they were open to them giving them resources. So this is a call to action to us to put those resources in those helpers' hands so they know what to give the kids when they're in front of them. And again, I feel that this window might be closing, so it's important to act. So as a pediatric psychologist, I'm weirdly comfortable in healthcare settings. I love being in them. The TEACH system is meant to be implemented into pediatric primary care on the West Side. So at UIC and Rush, which are actually neighboring each other, they're strictly on the West Side of Chicago. We've been working with them. So primary care is a centralized location with a lot of community and life integration. Rush also has some primary care offices that are integrated into schools on the West Side, where a lot of kids are getting their primary care. Primary care kind of takes some of the stigma out, because you could be there because your leg hurts, as opposed to telling a buddy you're going because you're feeling down and want to talk to your doc. And it's also typically visited annually. Between well child visits and illness, kids go through those doors. It's a great way to catch a lot of kids. So when we're asking the kids about the TEACH system or tools or screening, just being in primary care, they're actually very pro. And very excited about it. So like, it sounds good. It got us a grant. We had a good argument for it, right? And this is the 80s movie record scratch moment. And I know a lot of you are very gifted and talented in implementation science. You're going to laugh because you know exactly what the record scratch is about. Integrating into healthcare is a mess, and healthcare is a mess right now. So it's a big problem. In one study we just wrapped up, which was a collaboration between Northwestern, Rush, UIC, and Kasana Health, where we put a technology-enabled service that has an app grounded in behavioral activation into family medicine. We had planned on that technology-enabled service being run by medical assistants, because that's a really great way to integrate and keep the care environment really, really involved. And while the primary outcomes are still forthcoming, I can tell you that that's not at all what we were able to do, because the MAs were completely run thin. They could not think of an additional thing, even when we were in the design phase for this part of the study, to think about handing out a flyer to recruit participants. We touch on this a little bit in this paper, but we ended up having to involve lay level coaches instead of medical assistants. So I can tell you, like, we've already tried and failed in one recent study. For the TEACH system, while we've been doing our implementation planning with our stakeholders, there's been no ideal solution, right? So if we have paid research staff in the waiting room, there's a sustainability problem, because when the funding goes away, so does the paid research staff, as well as the waiting room can be kind of tricky for confidentiality. In MyChart, there's a lot of systemic access barriers. It's really hard to know if you're actually reaching a kid through MyChart as opposed to their caregiver. And additionally, we've done some recruitment for other studies through MyChart, where, it's the folks that are really easy to reach that are already on MyChart. It's not the folks that are hard to reach on MyChart, which makes sense, because that's another digital access tool. We also have a lot of docs that stand up and say they want to be our unexpected champions, but the docs have a lot of competing issues going on there. So we did a screening of Chicago providers this past summer, and every single provider was very clear that they are having so much trouble finding mental health referrals for teens that are timely, accessible, and appropriate. But most of them had not used digital tools for screening or recommended any to their teen patients. So they're begging for something, but they're not using any of the things that we've put out there. And when you ask about the feasibility of putting digital tools into primary care, they really don't see a feasible option for it. And in our interviews, again, with pediatricians who really, really care about their kids, they're saying things like, I don't want to find out at the end of an appointment for an earache that a kid's suicidal. And that takes my breath away because that's very important to me. But that pediatrician is thinking about the 25 kids they have to see after that appointment, and they're already running late. And I've had a lot of pediatricians say, it's great that you are trying to create this solution, and I don't know how to help you because we don't have enough to help you with this, but we also need what you're bringing. So please still do it, but it's not going to work. So the implementation interviews have made me sweat through a lot of clothes, but we'll keep working on it. So the lesson here, I think, too, is when we talk about lived experience, it's not only the kids and families we need to bring in as partners and keep on as partners on a continual basis, it's also our interdisciplinary colleagues. We've got to expand our bench with our teams. All right, I've chatted with you a lot, so I'll go quickly. Especially as you're thinking about other pediatric folks, I want to highlight two hometown heroes that are doing really cool community engaged digital mental health development in very different ways. So that's Dr. Chuka Amazewe and Dr. Alex Sihojos. So you see there's a QR code for Dr. Amazewe's lab. They're doing really cool stuff, really engaged with teens from the west and south sides of Chicago. They're keeping these teens on, they're doing creative writing contests, and they're developing really cool stuff, including the Brotherly Act app, which has been in development for some time and is super, super cool. Please check out their work. And then I also highlight Dr. Alex Sihojos, who's taking a different approach to community engagement. She's doing digital community engagement. So she's involving social media influencers to improve AYAs, adolescent young adults in oncology remission. So she's been partnering with folks such as Oh You're So Tough and Hot Cancer Survivor and Keanu Reeves' younger brother, who have a lot of content and followers with the oncology community. And they're collaborating to create content that both validates emotional experiences, but also increases adherence behaviors for their medication. So instead of it's the idea too of it's community-based participatory research transitioning to engage community members as equal partners. And Alex has done a beautiful job, like I said, of co-authoring with folks, responding to reviewer comments with her collaborators. She's done this really well. Okay, I'm almost there. So standing questions and takeaways. Another thing that keeps me up at night is just how ethically complex this is. Because every part of the Venn diagram of kids I want to work with is an ethical dilemma. So you've got pediatric patients who are minors, you're engaging them in a healthcare system. Boy, healthcare hasn't done right by a lot of folks. You're involving caregivers, providers who are also stakeholders, and the kids might see them wanting them apart in some places and not in others. Working with kids who have minoritized identities and socially complex needs, and then digital mental health itself with privacy and tech and all of that's packed in. It's a lot of ethical conundrums. Happy to chat. I'm sure you all have great ideas. And the other thing that I have mentioned too is we've got to figure out how to better power share, especially with youth, but also power sharing virtually is really tricky and something that CBPR does not really have insights for us. So I think this is something that we can work on. So in sum, we need to move away from one-time participant models. We need, if someone wants to participate for one time, that's fine, but we need to keep welcoming people to the table and keeping them engaged as our partners and really viewing folks as a team, whether that's our colleagues or that's community members or that's kiddos. And I like to also end with the idea that, Michael J. Fox has advocated that patients are the experts, and I'm in primary care, so that means everyone goes to primary care, everyone's the expert. But this quote often makes me think of something I saw on Twitter, and I don't remember who said it, so it's uncredited, and I haven't been able to find it since then, so I apologize. But this Twitter poster said that, people in healthcare are pilots. They can fly a plane, and they've flown, and that's great. But it's birds who actually know what flying is and what it takes to fly. So we got to work with the birds. These are my birds. This is my team that makes a lot of things happen. And I'm finally finished talking at you all. Thank you so much.
everyone's muted but clapping, so we're all literally and figuratively clapping. Thanks so much for that terrific presentation. We really appreciate it.